In this particular section, we are going to discuss on myelodysplastic syndromes. So it's very simple to understand myelodysplastic syndrome, to be honest, even though it's quite confusing at times. I have given the basics already in the previous videos, but still let me recap you once again. So you have a myeloid precursor cell or a myeloid progenitor cell. You know this is a multipotent stem cell, and any malignancy this, or even myelodysplastic syndrome is a like a proliferative disorder only, but this is also like a clonal stem cell defect. Stem cell means this myeloid progenitor is a multipotent stem cell. It's not a pluripotent or totipotent stem cell, but this is a multipotent stem cell. So it can give rise to many other lineages like erythrocytes, megakaryocytes, and even a lot of granulocytes and monocytes. So it is a multipotent cell. So this is the clonal defect of the multipotent stem cells, which are in this case is myeloid progenitor cell. So you know this cells has to differentiate and mature further. Differentiate and mature further. Suppose if there is a defective differentiation and maturation, if there is a defective differentiation and maturation of these cells, so what is really going to happen is they do differentiate and mature, but they are going to do with so much of difficulty, and the mature cells that are going to be produced are dysplastic. They are going to produce something called dysplastic cells. These are abnormal cells with abnormal shapes and abnormal constitution, and they do not mature properly, and they are having like a block in the maturation. So that is what we call as dysplastic cells, and which is a key feature of myelodysplastic syndrome. So whenever you have this kind of dysplastic cells, what is going to happen is two things will happen. One, these cells, only few of these cells will make out of the bone marrow. Number one, majority of them will go for apoptosis, and only few will leak out into the peripheral smear. Increase apoptosis in bone marrow, only few will leak out into the peripheral blood, and hence the peripheral blood, clearly you can see these cells having dysplastic changes. At the same time, since there are increased amount of apoptosis going in the bone marrow because of the dysplasia, there will be cytopenias which also can be seen in the peripheral blood. Along with this dysplastic change, there will be cytopenia. These cytopenias obviously will trigger increased hematopoiesis in the bone marrow, which means the bone marrow will become hypercellular marrow. So this is a paradox that is happening. You can see there is a cytopenia in the peripheral blood with a hypercellular marrow. Very important, which means the bone marrow is very, very active in producing excess cells, but they are inefficient and dysplastic. Because of that, there will be increased apoptosis, and they are not sufficiently entering the peripheral blood, and they are going to go for cytopenias. This is a very, very big paradox. So this is what you are going to see. First one, the most important thing is you will see dysplastic cells in the peripheral blood. Second important component of MDS is you are going to see cytopenias again in the peripheral blood. Third most important property of MDS is you are going to have something called an hypercellular marrow. Hypercellular bone marrow. These are the three hallmarks of myelodysplastic syndrome. The first two are really, really important. It's a must to diagnose MDS, but the third one can be optional. Why I am telling it's optional? Because there is an entity called hypoplastic MDS. There is an entity called hypoplastic MDS, which has typically an overlap with your aplastic anemia. I already told you, you have aplastic anemia, PNH overlap. Similarly, you have a little bit overlap with myelodysplastic syndrome also. So this area is where you call it as hypoplastic MDS. This is characteristic MDS, which will be hypercellular marrow, but this is characteristic aplastic anemia, which will have hypoplastic marrow or hypocellular marrow, but there won't be any dysplasia. So you can see here there will be dysplasia plus hypercellular marrow, and these patients with true aplastic anemia will have no dysplasia, you won't get any dysplastic changes, and you will have a hypocellular marrow. So it's totally opposite to that of MDS, hypocellular marrow. Clear? But this overlap patients, that is hypoplastic MDS, this is what we refer to as something called hypoplastic MDS, where patient will have a hypocellular marrow and a dysplasia of the lineages. That's why it's a overlap, hypoplastic MDS. Similarly, in PNH also same thing, only in PNH it's completely different. You are going to see something, like very different. You are going to see a PNH clone. This is here, you are going to see a PNH clone, but these patients will have a cellular marrow. PNH clone plus a cellular marrow. This is normal. This is what we refer to as called classic PNH. You can refer the PNH video if you want. But this subset of patients, if you ask me, which are having overlap with aplastic anemia, they are going to have PNH clone plus hypocellular marrow. Hypocellular marrow, depending on how much PNH clone is there, you can categorize into whether it's a aplastic anemia PNH overlap, or you are going to have your aplastic anemia having PNH clone in them. So you can differentiate, depending on that. So all these disorders are going to have pancytopenia or any kind of cytopenia. That's very important, because all these disorders are also stem cell defects, and they are acquired stem cell defects. All these are very important points. That's why I'm telling you there is an entity called hypoplastic MDS, where you might, very fraction, not that much cases you will see in hypoplastic MDS, but they may have a hypocellular marrow. But in general, these three are hallmarks of myelodysplastic syndromes. Clear? And one more important thing is, typically, you don't have splenomegaly in MDS, like myelofibrosis and all, you don't get really a splenomegaly in case of MDS. So if you see a good moderate spleen, then definitely the diagnosis goes against MDS. Usually MDS patients, we don't encounter this splenomegaly, to be honest. Okay, so next, moving on to the etiology. Etiology wise, you have one thing called idiopathic or primary MDS, where you see very common in the elderly population. Remember, this is the most common. Usually MDS is a disease that is seen around 70 years of age, which means almost 90% of the MDS are idiopathic or primary MDS only. That is the commonest thing, typically seen around 70 years of age. You have something called a secondary MDS, which can be seen in any age for that matter. This is not that common, it's only contributing to 10% of the cases, secondary MDS. So what are the causes of secondary MDS? You actually get with post-chemotherapy MDS. Post-chemotherapy, typically with alkylating agents, topoisomerase inhibitors, azathioprine, etc. This is also referred to as something called specifically treatment-related MDS. Okay. Second one, you have other things that can transform into MDH, like you can get with compounds like benzene. You can get after radiotherapy, you can get along with PNH also. Some patients with PNH also has overlap with myelodysplastic syndrome, which I didn't discuss actually, but yes, still some PNH patients may have, may develop and evolve into MDS, myelodysplastic. These are some of the important, this is the most important thing is the chemotherapy related MDS, that is called a treatment related MDS. So these are the etiologies for myelodysplastic syndrome. And what are the pathophysiology? Pathophysiology is what are the genes that are affected. The common mutations that are affected in a myelodysplastic syndrome are the ones that are important for epigenetic changes, epigenetic processes. I told you already, epigenetic changes, these are heritable DNA changes that are important for formation of different organ systems and different areas of tissues with different functions in the same DNA segment. Some should be silenced and some should be enhanced or expressed to produce the functions of that particular area. So we have discussed in detail about this, like epigenetic process already in one of the previous videos. So what are the mutations that affect the epigenetic changes? So there are genes that control this epigenetic process, like you have genes that are involved in DNA methylation, which is one of the very important epigenetic processes. Like for example, DNMT3A, then you have something called TET2, then you have something called IDH1 and 2. Clear? So these are the genes that are important for DNA methylation. The most important is the DNA methylase, DNMT3A. Then you have something called histone modification. What are the genes that are important for histone modification? You have something called ASXL1, then you have something called EZH2. These are some things that modify the histones. Number 3, genes that are involved in RNA splicing. The very important gene is SF3B1. And there are other genes that are also involved. Like for example, you have RUNX1. We have seen it many times. This is involved in transcription regulation. Then you have TP53, which is involved in DNA repair, guardian of the genome. Then you have RAS mutations, important for signal transduction. And you have something called STAC2 complex. This is a cohesion complex involved in mitosis. So these are the genes that are, other genes that are involved. For example, there are certain mutations like this ASXL1, and you have some mutations like SF3B1. These mutations are relatively specific for MDS. Or if you get AML along with these mutations, it is very likely to be a secondary MDS. That's what we take. This ASXL1 and SF3B1 are generally MDS related mutations, and if suppose a patient comes with AML with these mutations, obviously we are going to take it as a like MDS that has gone for AML. That's how we take it. That they are that specific for MDS. But certain all other mutations, for example, this RUNX1, TP53, DNMT3A, TET2, IDH1, EZH2, all these things can happen in AML as well as MDS. But remember, there are certain mutations that will not happen in MDS, will happen in AML only. AML only mutations are there. For example, you have one NPM1 mutation, FLT3 mutations. We have seen FLT3 inhibitors also, like midostaurin, like gilteritinib, crinolinib. Lot of drugs we have seen already in AML when we are discussing about the AML treatment. So FLT3 is very important for AML, and NPM1 is also important for AML. These mutations are not seen in MDS, they will be seen only in AML. Clear? So these are the important pathophysiology. At the same time, clinical feature wise, the most common clinical feature will be anemia, which is seen in almost 85% of the patients. Typically the anemia tends to be macrocytic, very important. Elderly macrocytic anemia, like always should give rise to a suspicion of a MDS, very important point. At the same time, patients may also have a leukopenia, especially a neutropenia, and this is seen in approximately 50% of the patients. And they can have a thrombocytopenia also, which can again be seen in approximately 50%, typically 40 to 65%, but I can write for simplicity purposes, I can write 50% of the patients. So most common is going to be the anemia, which is seen in almost 85% of the patients. Clear? So at the same time, even though, like for example, WBC count may only be marginally decreased, and that's also a very important point. And these patients are prone for infections. I'll tell you why. Even though neutropenia is there in 50% of the patients, but the infections that these patients get are going to be out of proportion to what the neutropenia is. Why these people are going to get infections out of proportion to what neutropenia is? Because the cells, whatever the neutrophils they produce, they are also defective and they are also dysplastic cells. Since whatever neutrophils they produce are also dysplastic and non-functional and they are dysfunctional, the infections what these patients are going to have is going to be out of proportion to the underlying severity of neutropenia. You might have a 3,500 numbers of neutrophils. I mean, you might have a good number of maybe 1,000, 1,200 neutrophils, but they may behave like a severe neutropenic sepsis. So that's also very important, but out of proportion infections in regards to the severity of the neutropenia. As I told you, splenomegaly is not a characteristic feature of MDS, that you have to know. So these are the only clinical clues you are going to get. Apart from that, you're not going to get any much clinical clues. The diagnosis will be based on investigations only, majority of the times in MDS. So what are the diagnostic clues? In the peripheral smear, typically I told you, you will be seeing dysplasia, either a unilineage or a multilineage dysplasia. Plus or minus, you will see megaloblastic changes, because in megaloblastic anemia means defective DNA maturation. Here what is happening? Same, defective DNA maturation and defective maturation of all lineages of myeloid precursor cells. That is the reason why you get megaloblastoid or megaloblastic changes. Then in bone marrow, typically you will see more than or equal to 10% dysplasia. This is a very important number for diagnosis also. You will at least see minimum of 10% dysplasia, plus you will see blast. So blast, most commonly it will be less than 5% blast, not much, but it can be up to 19% is possible. 19% possible, because please remember, anything 20% or more blast, it goes towards acute leukemia. So we can no longer diagnose a MDS. So up to 19% blast is possible, but typically it will be less than 5% blast only. Only in a condition called myelodysplastic syndrome with excess blast, in that condition you will have up to 19% blast, but in most of the times it will be only less than 5% of the blast in case of MDS. And patients in bone marrow may also show features of iron overload. That is because of poor utilization of iron. Clear? Bone marrow iron overload is common. That is because of poor utilization of the iron, because they do not mature properly, they do not utilize the iron properly. That is the reason, and that is also the reason why, like sideroblastic anemia, you can see ring sideroblast in some of the forms also. This is also very important finding. Clear? So what are the what are the dysplastic? We have been seeing about dysplasia, but what do you mean by this dysplastic changes? Let us see this image. So these are some of the examples of what you mean by dysplastic changes. You can see this is erythroid. R means these are the RBC lineage, erythroid lineage. So where you can see this is a multinucleate. This is a multinucleate polychromatophilic erythroblast. This is a polychromatophilic erythroblast. This is a polychromatophilic erythroblast. So this is definitely an abnormal erythroblast in the peripheral smear. This is not something to be seen. And second thing, you can also see lot of iron deposits. This is nothing but bone marrow iron overload. You can see this is Pearl's Prussian blue, and this is suggestive of iron overload, that all the blue dots are iron here. Whatever you see in blue in this are iron. So this is iron overload. Number 3, you can see these are erythroblasts that are nuclear bridging. You can see that nuclear bridging here. This is quite abnormal, clearly abnormal. This is the nuclear bridging over here, that is definitely abnormal. This RBC nuclear bridging is also not a normal one, it's a dysplastic one. And you can see these are ringed sideroblasts, and these are seen in the bone marrow usually. You can see something called ringed sideroblasts. Plus or minus, you can see uneven staining of the cytoplasm, especially cytoplasm, which is not shown in this particular image. Plus or minus, they can also have oval macrocytes. This is also sign of dysplasia only. Oval macrocytes we have seen already in the basics of the RBC. But come to the granulocyte lineage. What do you mean by some examples of dysplasia in a granulocyte lineage? Here you can see one such neutrophil. You can see they are having a very bizarre nucleus. In this condition, you can see a donut shaped nucleus or a ring shaped nucleus, which is very, very abnormal clearly, this kind of nucleus, surely. Then you can see this is a neutrophil actually with very poor maturation. They don't have granules, without any granules at all. This is called agranular monocytoid neutrophil, which means it appears like a monocyte, but it's not. It's a neutrophil. This is what we refer to as something called uneven staining, uneven cytoplasmic staining. That is, in this case, it's seen in the granulocyte. So here you can see a bilobe nucleus, nucleus of a neutrophil is with lesser lobes. This is what we refer to as Pelger-Huet anomaly. If you see without any associated condition, but since it's my MDS here producing this kind of anomaly, this is what we refer to as something called a pseudo Pelger-Huet cells. Pseudo Pelger-Huet cells. And you can see this we have seen already in megaloblastic anemia itself. This is nothing but a hypersegmented neutrophil. This is an hypersegmented neutrophil, and you can see a neutrophil and a myelocyte with an intensely basophilic cytoplasm. Remember, the basophilia will decrease over time. This is what we have seen in the beginning itself, in the basics of hematology and RBC, and the basics of stem cells and maturation, in the beginning of the hematology lectures itself. But here, even after maturation, there is a myelocyte and a promyelocyte and all these things, but still the base cytoplasm is intensely basophilic, and again it's an abnormal one. That's why it's a problem. It's a dysplastic neutrophil. Here what you are seeing is a megakaryocyte lineage. That's why you put M1 and M2. It's a megakaryocyte lineage where you can see a nucleus with discrete lobes. This is not possible usually without MDS. So this is what we refer to as something called a pond ball megakaryocyte. Pond ball megakaryocyte, which means it's nothing but a nucleus with discrete lobes. A pond ball megakaryocyte. Clear? So then this is also referred to as something called a mononuclear megakaryocyte. This is also abnormal. It should not be mononuclear. It should be multinuclear, but it should be usually, like I've shown in the, like myeloproliferative neoplasms part 1, I have shown one megakaryocyte in the essential thrombocythemia in the bone marrow. I still remember. So that is the one that is important. That's how the megakaryocyte that is proliferating should look. It's not like mononuclear like this. This is a mononuclear megakaryocyte, which is again very clearly abnormal. So these are some of the examples of dysplastic changes in the cells that you are going to look for. So some examples I told you about the dysplastic cells. Now coming to the classification of MDS. Classification of MDS. Classification wise, you have WHO classification in 2016 and you have WHO classification that has a 2008 nomenclature also. In both we have to differentiate. So what are things we have to differentiate in both? Number one, here something called MDS with single lineage dysplasia. In 2008, what is the norm? We called as something called multilineage cytopenia with unilineage dysplasia. This is multilineage cytopenia with unilineage dysplasia. Now we called as MDS with single lineage dysplasia. That's all. Clear? Here they called unilineage dysplasia. We are just changed to single lineage dysplasia. That's MCUD. So this itself has three different types. One is called refractory anemia, refractory neutropenia, or refractory thrombocytopenia. Three types have been described. But what you see in the peripheral smear? So let us see the peripheral smear findings and let us see the bone marrow findings. In the peripheral smear, at least you should have two lineage cytopenias and at least one lineage dysplasia should be there, and less than 1% will be blasts, which means typically you can call it as no blasts, but less than 1% will be blasts. Bone marrow will show definitely one lineage cytopenia, typically only one lineage dysplasia, because this is a unilineage dysplasia we have discussed already, and they will have less than 5% blasts. They will not have any Oyer rods to suggest it's a leukemia, and less than 15% will be ringed sideroblasts. When I write RS, it is ringed sideroblasts. So this is what the feature of MDS of single lineage dysplasia. Second one, here something called MDS of multi-lineage dysplasia. Previously this is also called as refractory cytopenia with multi-lineage dysplasia. These are all really good, names which have been there. Refractory cytopenia with multilineage dysplasia. That's how we're going to call it as RCMD. In peripheral smear, you will see 1 to 3 lineage cytopenias typically, and less than 1% blasts, or which means you are not going to see any blasts in the peripheral blood. Here again you will see, since it's multilineage dysplasia, you are going to see 2 to 3 lineage dysplasia definitely, and you will have less than 5% blasts, and you will not get any Oyer rods. Oyer rods are negative, and you will have less than 15% ringed sideroblasts. Clear? All these are very important. I'll tell you why ringed sideroblasts I am telling less than 15% all the time. Number 3, you have something called MDS with ringed sideroblasts, MDS-RS. So this is what we refer to as something called RARS, that's called refractory anemia with ringed sideroblast. What you're going to see here is only anemia. Only lineage cytopenia only will be there, that is anemia. At the same time, there will be less than 1% blasts, which means there are no blasts. In the bone marrow, you are going to see only erythroid dysplasia, only one lineage dysplasia will be there, that's erythroid dysplasia. Again, you will see less than 5% blasts, and you will not see any IR rods. But remember, there will be more than 15% ringed sideroblasts in the bone marrow. Very important point. That's why I was telling you from the beginning, less than 15% ringed sideroblasts, less than 15% ringed sideroblasts. Number 4, here something called isolated 5q deletion, MDS with isolated 5q deletion. Or previously, this is what we refer to as something called 5q deletion MDS. Remember, these patients are going to have again anemia as a very important clinical feature. Anemia is a very important clinical feature, plus at the same time they will have thrombocytosis. This is what I have been telling since long from essential thrombocythemia. So where MDS also can mimic a essential thrombocythemia because they have thrombocytosis. Typically they will have again less than 1% blasts, and it's very common in women than men. Remember, this thrombocytosis makes all the difference along with the anemia in 5q deletion. That is the usual thing that is helpful in exams to diagnose a 5q deletion, that's why. At the same time, what you will see here is normal or increased megakaryocytes, and these are the ones that are going to show dysplastic changes. Here, as we expect, it's not the anemia, it's the erythroid lineage that will be dysplastic usually, it's the megakaryocyte lineage that will be dysplastic. That's why this 5q deletion is very special. You expect something, but what you see in the bone marrow is something else. And typically again they will have less than 5% blasts, and they won't have any IR rods. And there will be less than 15% ringed sideroblasts if at all if present, and I don't think there will be any dysplasia in the erythroid lineage here. So that's why ringed sideroblasts are very rare to see, so there is no point in writing less than 15% ringed sideroblast here. And number 5, you have something called MDS with excess blasts. MDS with excess blasts, more than normal blasts. So you have two types, one is called RAB1, that's called refractory anemia with excess blasts, and you have something called RAB2, according to old nomenclature, that's called refractory anemia with excess blasts 2. Remember, what you are going to see is typically definitely a cytopenia, we don't know how many lineages, and again cytopenia, we don't know how many lineages. But remember, there will be 5 to 19% blasts. Sorry, here you are going to see 2 to 4% blasts, and here you are going to see 5 to 19% blasts. So which means definitely the blasts are increased. In previous, you have seen less than 1% blast, and suddenly blasts are increased to 2 to 4% and more than 5% up to 19%. So typically you will have dysplasia. It doesn't matter, it can be unilineage or a multilineage, we don't know. And again here also there can be dysplasia, and again it can be unilineage or multilineage, it doesn't matter. And in the bone marrow you are going to see 5 to 9% blasts. At the same time your IR rods will be negative. Here you are going to see 10 to 19% blasts. At the same time your IR rods will be negative. So excess blast means, remember, almost every single MDS patients will have less than 1% blast in the peripheral smear and less than 5% blast in the bone marrow. But only this excess blast category will have more than 1% blast in the peripheral smear and more than 5% blast in the bone marrow. Very important point. Cytopenias doesn't matter, whatever the cytopenia is, I don't care in this. Then you have something called an unclassifiable MDS, that's called MDS-U, unclassified, where in the peripheral smear you can see cytopenias which can be single or multiple lineage. Again you will see less than 1% blast in the peripheral smear, and typically you will have unilineage dysplasia, and in the peripheral smear you are going to see less than 5% blast. So this is all MDS unclassified. So these are the different features. Clear? So these are the important differences that you have to know. But let me put on a table. But before that I will tell you point number 1, Remember, the moment you see blast more than 20%, you are going to diagnose an acute leukemia. Number 2. Clear? Because acute leukemia patients also can have a lot of abnormal and dysplastic cells that is coming out. So blast more than 20% means it's acute leukemia. That's all. No need to go any further. And similarly, suppose if the patient is having monocytes more than 1000, plus if the patient is having dysplastic cells, typically it goes towards overlap syndromes. You have to be sure you cannot diagnose pure MDS. It's an overlap syndrome where you have to diagnose either a CMML or a JMML. Clear? Typically in adults we'll diagnose a CMML, chronic myelomonocytic leukemia, and it's not an MDS. And you have to rule out other cause of dysplasia. What are the other cause of dysplasia? You can have a B12 or a folate deficiency. You can have a copper deficiency. You can have HIV infection or any other viral infection if the patient is taking chemotherapy or patient is taking chronic alcoholism, and if the patient is taking heavy metals or if the patient is exposed to heavy metals like lead or arsenic. And even AML is one condition which can produce dysplastic cells. So you have to rule out all the other conditions that is associated with bone marrow dysplasia. All these things are very, very important. So now let us see how to differentiate each and every one. Let us put a small differentiation table. So how to algorithm like thing, how to diagnose this. First thing, is there really dysplasia? Is there really dysplasia? No, you are not dealing with MDS. You are not dealing with MDS. If you don't see any dysplasia, it doesn't matter. It's not MDS if you don't see dysplasia. If you see, yes, dysplastic cells are seen, then see blasts, the number of blasts. If blasts are more than 20%, blasts are less than 20%. If blasts are more than 20%, you are dealing with an AML, acute myeloid leukemia. Blasts less than 20%, see whether monocytosis is there, which means typically more than 1000 cells per microliter. If monocytosis is seen or no. If monocytosis is seen, you are seeing something called CMML, which is a MDS and MPN overlap. It's an overlap syndrome. CMML. You're not dealing with a pure MDS. Now only if it's no, then only you might be dealing with a pure MDS. Then you have to see percentage of the blast. See, ask the blast percentage. In the blast percentage, you are seeing there are a lot of options are there. You might be seeing 10 to 19% blast. You might be seeing 5 to 9% blast in the bone marrow, or you might be seeing less than 5% blast. Remember, if it's 10 to 19% blast, it is RAEB2. If it's 5 to 9% blast, as I told you in the bone marrow, it is RAEB1. But currently, both are classified under now MDS with excess blast. Anything more than 5% itself is not possible in the bone marrow, unless until this MDS excess blast is associated with. If it's less than 5%, then lot of other types are there, other things you have to classify. For example, next you have to see whether 5q deletion is there or not. Remember, if yes, and you can call MDS with 5q deletion. So this is a 5q deletion associated MDS. Remember, I didn't tell you this point. MDS with 5q deletion tends to be the most common type of MDS. Plus in the exam, please look for associated thrombocytosis. Very, very important point. Associated thrombocytosis. So 5q deletion. In cytogenetics, if you are not seeing the 5q deletion, then see what are the ring sideroblast percentage of the ring sideroblasts. So if the percentage of the ring sideroblasts are more than 15%, or if the percentage of the ring sideroblasts are less than 15%. Clear? If the percentage of the ring sideroblasts is less than 50%, you can call it as now what is the dysplasia? What is the amount of dysplasia? How much lineages are showing dysplasia? That's what you have to see. Whether it is a single lineage dysplasia or a multi-lineage dysplasia. Multi-lineage dysplasia. Remember, if it's a single lineage dysplasia, it is going towards something called MDS with single lineage dysplasia, otherwise called as MDS SLD. Very commonly in the previous era we are going to call it as RAMD or refractory anemia with single lineage dysplasia, or simply you can call it as refractory anemia. This is the old classification, but currently we call it as MDS with single lineage dysplasia, where you see typically anemia. If it's a multilineage dysplasia, you call it as MDS with multilineage dysplasia, MLD, but the old name is something called refractory cytopenia with multilineage dysplasia. This is where you see if the blast is less than 15%. If the blast count is more than 15%, I mean if the ring sideroblast is more than 15%, then again you have to see how much, how many lineages are showing the dysplasia, whether it's a single lineage dysplasia or a multilineage dysplasia. Clear? If it's a single lineage dysplasia, we call it as refractory anemia with ring sideroblast. That's called RARS. And again this will go towards MDS with multilineage dysplasia or refractory cytopenia with multilineage dysplasia, otherwise referred to as RCMD. That's it. So more than 15% sideroblasts with single lineage dysplasia, definitely that's erythroid, and that is what we refer to something called refractory anemia with ringed sideroblasts. And in all the steps I've told you something called dysplasia here. Dysplasia here. So you have to know what percentage of dysplasia will contribute to the, significant dysplasia. To call MDS, what is the percentage of dysplasia unit? At least 10%, very important number. At least 10% dysplasia is needed to put it under MDS in the first place. Very important point. So I hope this table will make a lot of sense. So even though it's this algorithm will make a lot of sense, even though it's a big algorithm, but it is clearly going to help you in finding out what is the exact, way to find out what is the type of MDS in a very easy way. Next, as we moving on to our hero, cytogenetics. A lot of cytogenetic changes. You can start from something called a very good cytogenetic change. You also have a good cytogenetic changes in MDS, and you have some intermediate cytogenetic changes. Then you have poor cytogenetic changes, and you also have very poor cytogenetic changes. What are the very good cytogenetic changes? Which means cytogenetic changes that have very good impact or outcome on prognosis. Deletion of Y, and you can see deletion of 11q. These two are, especially this 11q has been asked already, that's why I'm telling. So 11q deletion, good prognosis. Very good prognosis. Good prognosis, typically when you have a normal cytogenetics, or you have a deletion 5q, or you have a deletion 20q, or you have a deletion 12p. In this, most importantly, they have asked is the deletion 5q and normal cytogenetics. Clear? 5, 20, 12. Simple. Then intermediate prognosis, there is something called double dependent clones. I don't want to explain what is this. It's something easy to understand, but still it's a time killer. So there is something called double dependent clones, and all others that will not come under any of the other classification can also be put under intermediate prognosis. Poor prognosis, you have something called deletion 7q, then you have something called inversion 3, then you have something called deletion 3q. In this 7q and inversion 3 they have asked already. So that's why this is important. Then very poor cytogenetics, you have complex chromosomal abnormalities, like more than 3 abnormalities at least will go towards very poor prognosis. This is a very important point again. In this, if they want to ask, they will ask you deletion 11q, normal cytogenetics, 5q, 7q, inversion 3, and complex karyotyping. So these are the things that you have to know. In that, please don't forget 5q deletion. It's a very good prognostic thing. 5q deletion is associated with a good prognosis. Very important point. And for scoring MDS, we have something called IPSS scoring. That is called IPSS-R is what we call International Prognostic Scoring System, where it uses 5 criteria. One is called marrow blasts, how much blasts are there in the marrow. Then you have cytogenetics. Then you have hemoglobin, platelet count, and absolute neutrophil count. So these are the 5 things that this IPSSR is going to use, and it's a big thing, no need to remember. So they're going to be different scoring system for 0, 1, 2 like that. 0, 1.5, 2.5, 2, 3, 3.5 like that. So you have a lot of different scoring system are there. Supposedly, if the score is going to be less than or equal to 1.5, it's said to be very low risk MDS. If it's supposed to be 1.5 to 3, we call it as just a low risk. If it's 3 to 4.5, we are going to call as intermediate risk MDS. And if it's 4.5 to 6, we call it as high risk MDS. And anything more than 6, we are going to call it as very high risk MDS. This is something integrated, not only based on cytogenetics, it's integrated based on a lot of other factors also. So this is what we call MDS scoring system. And we have a finally treatment. Treatment wise, it depends on whether what is the performance status and what is the risk. If it is a poor performance status, or which means it's unfit patient, that's what I mean really, then it's a good performance status, which means a fit patient. A poor performance status patient, irrespective of the risk, any risk, if he is poor performance status, we are only going to give a supportive care. Supportive care. For example, we are going to treat the cytopenias. For example, you can treat erythroid stimulating agents for anemia. You can use GCSF for neutropenia. You can use TPO mimetics like L-Thrombopag, Romiplastim. All these things you can use for thrombocytopenia. Plus or minus, since they are prone for infection, you can give antibiotics. Plus or minus, you can give iron chelation also. Clear? So these are things that you can give in these patients additionally. That's a supportive care. Always remember, one of the important GCSF is filgrastim. This filgrastim is also with increased risk of splenic rupture in MDS. This is very important point again. I have personally seen a case, that's why, very rare case, a 74-year-old gentleman who is actually a Vellore District Court judge actually. I have seen this patient, we have treated with filgrastim in around 2nd or 3rd month he went for splenic rupture and he collapsed and died. So anyway, that's why this is one thing I can't forget. So this filgrastim associated with increased risk of splenic rupture in MDS. If it's a good performance, you can categorize under whether it's a low or intermediate risk, or you can put under intermediate to high risk. Intermediate to high risk. Clear? If it's low or intermediate risk, then I can use drugs like lenalidomide. This will typically work for 5q syndrome. This is actually very good drug for 5q syndrome. Or you can use like DNA hypomethylating agents, DNA methylase inhibitors, DNA hypomethylating agents. What are the DNA hypomethylating agents you have? Like you have azacitidine and decitabine. These are the DNA hypomethylating agents. Remember, usually this DNA hypomethylating agents will work very well for this TET2 mutations. So they will work very well for this TET2 mutations, which is again is very important in MDS. So this is what you're going to do. And plus supportive measures also you can do here. As like other people you can do supportive measures, but I don't want to tell once again. Like you can use your ESAs and all these things, especially EPO less than 100. So intermediate to high risk, you can better plan for allogenic hematopoietic stem cell transplant if they are fit. If they are unfit, then you can use DNA hypomethylating agents if you feel they are unfit. Okay, this is all for routine MDS that you are going to use, but there is another entity called, I told you, hypoplastic MDS. Hypoplastic MDS. Remember, hypoplastic MDS is actually in overlap with aplastic anemia. That is the reason we will be treating this with immunosuppression ideally, because how we treat aplastic anemia, like that only you are going to treat this. You are going to treat with immunosuppression with either a cyclosporin or a ATG and steroids. Plus or minus, you can give hematopoietic stem cell transplant. What will determine that the hypoplastic MDS will respond to steroids better? These points I don't know whether they will ask or not. So So whenever you give immunosuppression in a hyperplastic MDS, the predictors of response are only two things. One is called HLA-DR15 and second is if there is a presence of PNH clone in the periphery. So if you have a PNH clone associated or if HLA-DR15 is positive 1,5, so in that condition you can see a good response to immunosuppression. Otherwise the response to immunosuppression may be average. You won't see that much of a good response. So this is all what about you want to know about myelodysplastic syndrome. And there are two overlap syndromes I'm going to talk about. That is called MDS MPN overlap. So there are two overlap syndromes. One is called CMML and second one is JMML, juvenile myelomonocytic leukemia, and CMML is chronic myelomonocytic leukemia. Both will have features of both MDS as well as myeloproliferative neoplasm. Typically remember, in both this they will have monocytosis. Both will have monocytosis and both will have myeloblasts, but less than 20%. Monocytic more than 1,000 here. And the myeloblast, that the blast count in the bone marrow will be less than 20% in both. So this is in the peripheral smear and this is in the bone marrow. Myeloblast less than 20%. Otherwise it will go towards acute leukemia. So it should not be more than 20%. At the same time, both will show dysplasia. Lot of dysplastic cells. Clear, which means you are having increased cell production. At the same time you are having dysplasia also. That is the reason why this goes, and you have a hypercellular marrow also. So that's what it's going to tell you. It's an overlap. It shows the features of both MPN, which show increased cells in the periphery. At the same time it shows hypercellular marrow like MPN and MDS. At the same time it also shows us dysplasia, which is like MDS. So that's why it's an MPN MDS overlap syndrome. And typically how they are going to present is like leukocyte. In this patient's clinical feature, they are going to come with skin rash very commonly, and they can come with gum hypertrophy, and they will have splenomegaly. So this is the classic presentation how this CMML is going to come. The skin rash, gum hypertrophy and splenomegaly was already asked in exam. So clinical features, what you are going to see, typically age will be less than 4 years and patients will have skin rash as usual, which will be typically eczematous skin rash, and patients will have associated lymphadenopathy and hepatosplenomegaly. This is how they are going to come in a juvenile, almost similar presentation, not much difference. Juvenile myelomonocytic leukemia. And what are the changes that you can see? Here remember, before confirming its CMML, you have to rule out certain conditions like CML, which means you have to rule out the BCR-ABL translocation. You have to rule out BCR-ABL translocation. You have to rule out this PDGFR A and B translocations, and you have to rule out this FGFR1 translocations. Remember, this PDGF receptor A mutation will lead to something called a chronic eosinophilic leukemia, right? This PDGFR-B mutations will lead to, rearrangements will lead to something called chronic myelomonocytic leukemia with associated eosinophilia. That's a separate disorder that responds to imatinib, which we have seen already. This FGFR1 rearrangements will result in something called 8p stem cell syndrome. We know that already. And BCR-ABL is going to result in many other conditions like ALL. It can be seen in AML, but here less than 20% blast, so it's not acute leukemia, so it can be CML also, so you have to rule out that also. Then only you can make a diagnosis of this CMML. Remember, treatment is only allogenic stem cell transplant, allogenic hematopoietic stem cell transplant. It's very difficult to treat and it's a very aggressive tumor, and the patient usually dies fast and it's a poor prognostic state. Here there are some other important points other in JMML. In JMML there is some association. It's very similar to CMML but happens in age less than 4 years, and usually associated with two disorders. One is called neurofibromatosis 1 and second one is something called Noonan syndrome, which is due to PTPN11 mutations. It's a well-known fact. PTPN11, very important thing in pediatrics. Then usual Here I told you, you will see, this thing, but this monosomy 8 is very common in JMML. The monosomy 8, this is also one of the PGI questions in the past. So monosomy 8 is a very common thing in JMML. And treatment again, poor prognosis and very high risk of transformation into aggressive forms of AML. So again, you are going to go for allogenic hematopoietic stem cell transplant. So these are the two MDS and MPN overlap disorders. Both have relatively similar thing. Remember, monocytosis myeloblast, but see the age. Actually, presentation may be the same. See the age. That is the clue for differentiating between these two. Otherwise, you will be different. Remember, this CMML and JMML will not respond to imatinib because they are not associated with PDGF receptor mutation. Rearrangements. PDGF receptor rearrangements will definitely respond to imatinib. Like for example, I told you CMML with eosinophilia, chronic eosinophilic leukemia, all these things will respond to imatinib because they are PDGFR associated, but this will not respond to imatinib. Clear? You need only allogenic hematopoietic stem cell transplant, allogenic HSCT. So with this, we are concluding our huge topic, that is myelodysplastic syndromes also. I think this much, if you know in myelodysplastic syndrome, is enough. Especially the algorithm which I showed you will help you in big time in exam if they ask you a specific type to diagnose. But on the other hand, most of the questions supposed to be one-liners before, but since the trend is changing, it's also important to know the clinical features of each and every myelodysplastic syndromes as well.